Hello everyone, welcome to my YouTube channel, Dr. Akif Baig. Today we will be talking about spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis is a term used to describe acute infection of the ascites, that is a fluid accumulation in the abdomen without a distinct or identifiable source of infection. So this infection is usually found to be associated due to the bacterial translocation. So what happens is bacteria from the intestine translocates into the abdominal cavity, that is in the ascites, and thus leads to infection of that. That's called spontaneous bacterial peritonitis. It's commonly presents with the symptoms of spine. Symptoms and signs are abdominal pain, tenderness on palpation, and ileus, that is decreased movements of the intestines. However, up to one-third of the patient may be asymptomatic or present with only encephalopathy and/or acute kidney injury. The diagnosis of SBP is established with a fluid. That is, you have to remove an ascites fluid for diagnostic purpose, and if there is absolute neutrophil count of greater than 250 per millimeter cube, it is going to be diagnostic of SBP, and it has to be established with a positive blood cultures later on. Because the presentation of SBP is variable and the delay in insulin therapy can lead to increased mortality, a diagnostic paracentesis should be performed as soon as a patient with cirrhosis and ascites is hospitalized for any reason, even in the absence of symptoms suggestive of infection or whenever a patient develops signs suggestive of infection. So what does it mean is that if suppose any patient who has been diagnosed with a cirrhosis and ascites, it is present to the emergency department due to any reason, if whether the symptoms are present or not of the infection, you have to do a fluid diagnosis. That is, ascitic fluid should be aspirated and sent for absolute neutrophil count, irrespective of the infections. So in patients with tense ascites and acute kidney injury, a diagnostic paracentesis is recommended to exclude SBP as a cause of the acute kidney injury. So also, if a patient may not have only abdomen pain, he may present with acute kidney injury as well as with encephalopathy. So usually the most common organism in the 60% of cases is gram-negative bacteria and then fungus, representing less than 5% of infections. And among the gram-negative bacteria, the most common organism is being E. coli, followed by Klebsiella pneumonia, Staphylococcus aureus, Enterococcus faecalis, and Enterococcus faecium. More recently, there has been shift towards gram-positive bacteria, and there has been found to be a multi-drug resistant organism due to inadvertent use of antibiotics over the counter, so which has led to multi-drug resistant organisms. So management in all patients whose ascites polymorph, that is absolute count of more than 250 per millimeter cube, patient has to be started on IV antibiotics empirically. So, and also this fluid has to be sent for culture. So patient with a focal intra-abdominal inflammatory entity like diverticulitis, cholecystitis may also have an ascites polymorphonuclear count of more than 250 millimeter cube and should be treated not for SBP but for the specific condition. So suppose a patient has been done ultrasound, if a cirrhosis patient is there and having ascites, but he has also found of diverticulitis or cholecystitis, he should be treated for this entity rather than treating them as SBP. So traditionally, the third generation cephalosporins, that is ceftriaxone, cefotaxime, were recommended in all patients with SBP with the resolution rates of approximately 90%. Currently, they are recommended as a first-line antibiotics in settings where multi-drug resistant organisms are not prevalent. So, inappropriate initial antimicrobial therapy in patients admitted with septic shock increases the risk of death by 10 times. So, suppose the patient has been admitted with septic shock, hypotension, tachycardia, and having a known case of cirrhosis with ascites. In that case, you have to suspect them of having a multi-drug resistant organisms, and you should try to cover them also. So you should not only start with IV ceftriaxone as used to be used before, because now there is increased prevalence of multi-drug resistant organisms. You have to start them on carbapenems, which may decrease the mortality, because if you don't treat the patient of shock in time, the risk of death may be increased by 10 times. So in general, patient with risk factors for multi-drug resistant organisms should receive piperacillin tazobactam with vancomycin added in patients with prior infection or a positive surveillance swab for methicillin-resistant Staph aureus. Daptomycin should be added in patients with prior infection or positive surveillance for vancomycin-resistant Enterococcus. Patient with current or recent exposure to piptas, that is piperacillin or tazobactam, should receive meropenem with or without a glycopeptide, that is vancomycin or teicoplanin. So given increased recent failure rates of initial antibiotic therapy, which may lead to increased mortality. It is recommended that a diagnostic paracentesis be performed 48 hours after initiating antibiotic therapy to assess response. Suppose the patient is already having a good response, then routine diagnostic paracentesis is not required. A negative response is defined by a decrease in PMN count of less than 25% from baseline. So, and then you have to look for changing the antibiotic and also to investigate for secondary peritonitis. The recommended duration of antibiotic therapy is 5 to 7 days. Acute kidney injury in SBP, bacterial infection in patients with cirrhosis are a common precipitant of acute deterioration leading to worsening hepatic decompensation and multi-organ failure, with the kidney being the most commonly affected organs. Conversely, the development of AKI is the main predictor of in-hospital mortality in patients with SBP. So the role of albumin in SBP in patients with cirrhosis and an infection, albumin plays a much more important role than as a simple expander of the intravascular volume. So in importantly, patient who most benefit from albumin were those who already have some evidence of renal dysfunction, that is blood urea nitrogen of more than 30 or a creatinine of more than 1, or patient having severe hepatic decompensation with a bilirubin being more than 5 milligram per deciliter. These patients will be most benefited from the albumin therapy, and the recommended doses for them is 1.5 grams per kg body weight on day 1 and then 1 gram per kg on till day 3. So it has been the standard recommendation, especially has to be preferred in patient of cirrhosis, ascites with renal dysfunction and severe hepatic decompensation. Secondary prophylaxis, the patient who has developed one episode of SBP, they are at very high risk of developing SBP recurrence later on as well. So in a landmark multicenter randomized trial, the 1 year probability of developing recurrent SBP was with norfloxacin was 20% compared with placebo 68%. So previously, norfloxacin was the drug of choice for secondary prophylaxis. Now, reasonable alternative to norfloxacin, that is oral ciprofloxacin, is being preferred, that is 500 milligrams per day. For primary prophylaxis, routine antibiotic therapy in all patients of cirrhosis and ascites is not recommended. However, patient who have a highest risk of infection or SBP, that is any patient with cirrhosis and having acute upper gastrointestinal bleed, or patient having a low ascitic fluid protein, that is less than 1.5 gram per deciliter. So this two patients, group of patients will definitely benefit from prophylactic antibiotics, and antibiotics should be given prophylactically in this patient. And the drugs commonly used for them is norfloxacin or IV ceftriaxone or rifaximin. Hope you have liked this video. If you want to see more videos like this, do subscribe to my YouTube channel, Dr. Akif Baig. Thank you.